Zoe, this is Megan. She is G3P2 at 30 weeks gestation. So how are you today, Megan?
I'm good, but I have a question for you today. My friend who's currently experienced pelvic organ prolapse told me that childbirth and parenting are the main causes for pelvic organ prolapse. Is that true?
Zoe, do you know anything about pelvic organ prolapse?
Pelvic organ prolapse is when the pelvic tissue and muscles that support the pelvic organ lose their strength and bulge down into the vagina.
So, what are the pelvic organs?
Your pelvic organs are consisted of bladder, uterus, vagina, and bowel.
The pelvic floor is an area of muscle and connective tissues that fill the outlet of the bony pelvis, separating the pelvic cavity above from the perineal region below. The main muscular component of the pelvic floor are called levator and nine, which is a deep muscle layer comprised of three major muscle groups. This deep muscle layer is important in maintaining the strength of pelvic floor. It also provides voluntary control of the urinary and anal sphincters. In relate to childbirth, pelvic floor facilitates birth by resisting the descent of the presenting part, causing the fetus to rotate forwards to navigate through the pelvic girdle.
Childbirth is one of the major causes of pelvic organ prolapse because each of these structures can lose its strength to support through birth trauma. But there are more causes such as menopause, obesity, chronic cough, routinely heavy lifting, and aging or estrogen loss cause intrinsic weakness can also result into pelvic organ prolapse. Prolapse is divided into three main groups, which are uterovaginal prolapse, anterior vaginal wall prolapse, and posterior vaginal wall prolapse. Uterovaginal prolapse is the descent of the vaginal vault, uterus or uterine cervix, where anterior vaginal wall prolapse is commonly related to the descent of the bladder or urethra, which could possibly lead to urinary stress and incontinence. Posterior vaginal wall prolapse is the descent of the small intestine or rectal protrusion, which can make bowel motion more difficult.
How do I know if I got pelvic organ prolapse?
As mentioned previously, urinary stress and incontinence is one of the most common symptoms. This is because prolapse could cause the dislocation of the urethra. It can also cause leakage of small amount of urine when coughing and sneezing. There are other symptoms that women may experience with prolapse, such as the feeling of something dragging or coming down the vagina or pain in vagina, back and abdomen. Vaginal discharge with stained blood or unpleasant smell, painful or less intense sexual sensation, as well as constipation are also signs of pelvic organ prolapse. These symptoms depend on the type of prolapse and how much pelvic organ support has been lost. It is common that women can have a prolapse but not have any signs from it. It may get noticed by a doctor or nurse when you are examined for another reason, such as during cervical screening. In New Zealand, there is a system called Pelvic Organ Prolapse Quantification System, which identifies different stages of prolapse of the uterus. There are 4 grades for uterovaginal prolapse degrees. Grade 1 is when the uterus has descended into the lower half of the vagina, where grade 2 is when the cervix is near the opening of the vagina. Grade 3 is when uterus, cervix, and the protruding tissue are outside the vaginal opening. When vagina, uterus, and cervix are completely outside the vaginal opening, has been recognized as grade 4.
What are the available treatments for prolapse?
There are 2 categories for pelvic organ prolapse treatment. The first being non-surgical treatment, which includes exercise, pessary use, biofeedback, and there are also surgical treatment being the second category.
Can you tell me a bit more about them?
Pelvic floor exercise can improve the muscle activation, contractility of the pelvic floor muscle, and decrease the occurrence of urinary leakage. However, pelvic floor exercise can only improve outcome in short term, and chances of prolapse or incontinence recurrence will increase later. Another non-surgical treatment is physical therapy, and it is often performed through the use of biofeedback device. This device is an external sensor that is placed in the vagina, rectum, or on skin to monitor the woman's pelvic floor. by watching the strength of the contraction when the woman contracts the pelvic floor muscle. Vaginal pessary is the most effective non-surgical treatment for women who wish to delay surgery, still wanting more children, avoiding surgery due to physical or financial complication, and for those older women who are at higher risk to do surgery. Vaginal pessary is inserted into the vagina to support the pelvic organs. There are many different types of pessaries, but only ring pessary and tube pessary are most commonly used ones. Pessaries can be safely stayed in the vagina for several months. Every 6 months, the woman needs to revisit the nurse to review on her experience with the pessary to find out whether a different shape or size pessary needed to replace in order to find the perfect fit. It often needs a few tries to find the perfect size or shape of the pessary. All types and grades of prolapse are suitable to use pessary. For women who still wanting more children, only certain types of pessary, such as ring pessary, are suitable to have sexual intercourse. Very often for older women, estrogen cream will be used along with pessary. This is because after menopause, vaginal skin will be dry and thin due to lack of estrogen. This can lead to ulceration, which is bleeding when the pessary is inserted. Long forgotten pessary is also a very common and a serious risk factor.
If your symptoms of prolapse are getting worse, or that you found the non-surgical treatment not as useful, surgical treatment may be needed. The surgery can be performed in two ways, either working through narrowing part of the vaginal canal or down through an incision in the abdomen or vagina. For posterior prolapse, it is to secure the connective tissue between vagina and rectum to reduce the size of bulge, whereas anterior prolapse needs to readjust the bladder to the right place and secure the connective tissue between vagina and bladder to keep the bladder in the proper position. Uterovaginal prolapse is more complicated. Uterine prolapse may require removal of the uterus, and for vaginal valve prolapse, it is required to place synthetic mesh in vagina to help with the support of vaginal tissues. Even though surgical treatment has the benefits of low morbidity and long-term success, however, there are still some possible risk factors, as some women may have difficult passing urine after an anterior repair, and this will lead to the requirement of urinary catheter. 5% of women may need surgery for recurrent prolapse. Infection is also another very common risk factor. For older women, health issues prior surgery may have effects on the outcome of the surgery. For women who still plan to have more children, may wish to delay surgery until her family is completed, as the surgery can involve in the removal of uterus. After surgery, there is potential pelvic pain and pain during sexual intercourse. Recovery time is required after surgical treatment. During this period, women should avoid heavy pushing, pulling, or lifting, and no vigorous exercise for at least 6 weeks.
This is really good to know, thank you.
I can totally understand your worries, and researchers did show that vaginal delivery is a causative factor in pelvic floor dysfunction with the risk of pelvic organ prolapse. Especially for women who have instrumental deliveries, are at increased risk of anterior and posterior vaginal wall descent. Vaginal delivery with forceps triples the risk of pelvic floor damage, but there are other risk factors that may cause pelvic organ prolapse. For you, Megan, you have a normal uncomplicated pregnancy and not encountered with most of the risk factors that have been mentioned previously.
How about parenting? I heard the increase of parenting will result in pelvic organ prolapse. And what if I do have an instrumental birth?
Research has shown that parity are much higher in women who suffer from prolapse. But Megan, this is only a third pregnancy, so you are still in a lower risk of prolapse. In case of instrumental birth, I cannot say you will definitely not have an instrumental birth, as each birth is different. But baby is in a normal weight range, also lying in a left anterior position with head down and pelvis. Your previous birth are also normal vaginal delivery with no complication, so you are less likely to get an instrumental birth this time as well.
When you are in labor, I will guide you throughout the whole process to avoid pushing and deliver baby until the cervix has been fully dilated. I will also ensure the second stage is not prolonged without obvious progress, and if there is any perineal trauma, it will be carefully repaired by me or the doctor. During the postnatal period, I will demonstrate to you the correct steps of pelvic floor exercise.
What if I really found myself having those prolapse symptoms? Where do I look for help? Should I come to you again or visit my GP?
If a woman really finds herself having these symptoms, she will need to go to her GP, then the GP will refer her to the specialist service to see an urogynecologist consultant. The consultant will perform a diagnostic test, which is a pelvic examination to identify the type of prolapse and the level of descent. After the diagnosis is established, the consultant will further discuss with you what treatments are available. If you decide to have a surgical treatment, a day will be arranged to perform the surgery, and after surgery, the urogynecology nurse will follow up with you after 6 weeks to see how everything is going. If you choose to have a non-surgical treatment, the nurse will either refer you to the physio if needed. Vaginal pessary will also be done with a nurse, and the woman will need to visit the nurse every 6 months to have a review on the use of pessary. For pregnant women who previously experienced prolapse, I would also refer to the consultant and arrange a care plan with them.
This is very clear for me now. When I was talking to my friends about her experience on pelvic prolapse, she explained that she was very lost and embarrassed when she found out she had the symptoms of prolapse, and she thought she has to wear adult diapers for the rest of her life. She doesn't even know there are treatments, and she has no idea where to look for help.
Yes, I do understand how she felt, as researchers show that women living with pelvic organ prolapse describe feelings of self-consciousness, isolation. Some women express anxiety about how the pelvic organ prolapse affect their relationship with their partner. Embarrassment and discomfort brought on by prolapse have caused some women to change their sexual life, and many women also reported that they completely avoided physical intimacy and sexual intercourse with their partner. Also, it has an impact on their work and daily activities.
I know some studies has proven that poor health literacy is one of the causes that stop women to seek for health care, especially because New Zealand is such a multicultural country. Women who has less knowledge about treatment options are usually due to their language barrier, as they cannot understand English, which made it more difficult for them to look for help. Women from lower socioeconomic background have heavier financial pressure on them. These women are responsible for heavier manual work, and usually they return to work soon after a delivery. This has increased the risk of getting prolapse. Study has also proven that women with higher education tend to know more about their own body, have better sense to acknowledge problems, and get appropriate health care without delay.
Yes, I totally agree. I think New Zealand is working pretty hard to help those women. Paid parental leave and health subsidies has really helped those women from lower socioeconomic side. I have also seen lots of health pamphlets in different languages in JP's office and other places. I found that they are quite useful for women who has English as their second language to understand more about their body and what help and treatments are available out there.
Is there anything else you want to ask?
No, thank you for all the information.
We will talk about the exact birthing plan during next appointment.
That sounds so good. See you next week.
See you next week.